though physicians, they go to school for years and years and they train to become experts in the body, it isn't just about the physical aspects of living with disease and illness. And so it is how we communicate with patients that can really make a difference. And patients, we are not trained to be effective communicators in medicine, right? Physicians go to school and we receive no formal training. And so we're thrust into these really difficult, emotional, distressing situations where we're dealing with uncertainty and we're having to make these decisions sometimes very quickly. One of the main causes of miscommunication in medicine between patients and doctors is that we have different assumptions and oftentimes have different goals. So if you think about patients, we often feel like physicians just want us to get to the point, right? They're super busy. They're leaning on the door. They're looking at their iPad. And I want to acknowledge that physicians live in a really hard time right now. They're functioning in a really difficult space as well. So they are pressed for time. And what I think is really important here in patient centered care and shared decision making is that it is the patient who is an active health participant, an equally valued member on the team, right? We are the experts of our bodies. And so shared decision making is this collaborative process between patients and clinicians, and sometimes family members, right? Depending on the context. And it's integrating, okay, what's the best available information and evidence with the patient's values and preferences. So what matters most, to us. And so shared decision making really works best when clinicians are clearly explaining the relevant evidence, right? The pros, the cons, the risks, the benefits, but then also supporting and understanding the values and preferences of the patients. And
this is Genetics for Healthcare, a podcast for patients.
Welcome to another episode of Genetics for Healthcare, podcast dedicated to patients and their caregivers to figure out this world of genetics and genomics, what they mean to us and the implications they have for our healthcare. Our goal is to help you learn the language and build the confidence to have these conversations with your care providers and your family members to see how you can use this information for screening and prevention of diseases. And also, if you're battling diseases, treatment and survivorship. Find us on geneticsforhealthcare.com. Today, we are privileged to have Dr. Marlia Dean Cruzel, who is an associate professor at the University of South Florida. I had the privilege of meeting her at a great event, and she's here to tell us about her Genetics for Healthcare journey to survivorship and help us also uncover root causes of ways to avoid miscommunication in healthcare. Dr. Cruzel, thank you for joining us on Genetics for Healthcare.
Thanks so much, Rome. It's a pleasure to be here. Super excited to connect.
So I know you from your battle of being a previvor. So tell us about what previvorship is and your family history with cancer and how that come to be to get this information to make those decisions?
Yeah, that's a great question. So my journey with being a previvor really starts with my mother. My mother was 38 years old when she found a tiny, hard, like a pea-sized lump in her left breast. And I was 8 years old at the time. And she was, soon after she discovered that lump, diagnosed with breast cancer. And so the next couple of years, I watched her undergo surgery on her left breast. Then she had chemotherapy and radiation. And then she decided to do a prophylactic mastectomy on her right side, on her right breast. And then finally, reconstruction for both breasts. And this was in 1997. It was very traumatic for her surgery, the scarring. And then 2 years later, my mom's younger sister was diagnosed with breast cancer, also at 38 years old. And this then led my mother's older sister to really start investigating our family tree. And we learned that my great grandmother died of breast cancer at 35 years old. And that was
Mm.
just a couple years after giving birth to my grandfather. So that's kind of the origin of, the start of my story. And the term previvor is something that I've come to embrace since I tested positive for an inherited mutation in the BRCA2 gene. And the term previvor was coined by the national nonprofit organization FORCE, or Facing Our Risk of Cancer Empowered. And it was really motivated by this need to not dismiss significant ongoing stress and the complex decisions facing individuals like me, and recognizing us as survivors of a predisposition to cancer. But I also want to note that not every patient with inherited gene mutations really embraces or thinks of themselves as a previvor. So, these are people who have not been diagnosed with cancer, but that isn't something that identity isn't something that all patients embrace.
So, when your mother and your aunt were diagnosed with breast cancer, I'm not sure of the time frame, but I don't know if BRCA testing was available at that time. Certainly not well known, maybe not even covered by insurance. But when you became of age, how was the topic of genetic testing introduced and offered to you and your family? And what made you arrive at that decision to
Mhm.
embrace your previvor identity? As you said, some don't.
Yeah, so you're absolutely right. My mother was diagnosed in 1997, so we're just at the beginning of Dr. Mary King Claire discovering, BRCA, and just, starting that whole trend. My mother was actually the first one to undergo genetic testing in our family, so she's what we call the proband to define our jargon. But this was several years after being considered a survivor. Her oncologist first talked to her about genetic testing, and then her gynecologist, excuse me. And so she did undergo genetic counseling and then testing, and tested positive for an inherited mutation in the BRCA2 gene. For me, so this was 2010 when she got her genetic test results. So a lot later from when she was diagnosed originally. But um, at the time, I was just starting a PhD program in healthcare communication. And so when my mom got her genetic test results, I remember her saying, this is the reason why breast cancer runs in our family. And you should think very hard and carefully about whether you want to undergo genetic counseling and testing too. And so it was a couple years after I learned about her mutation, and then both of my aunts also tested positive too. But so I was working on my PhD in 2012, and I saw a genetic counselor. My mother, my husband, they attended the appointment with me, and at the end of the appointment, I felt like I had a really good understanding about, my possible lifetime risks of cancer if I tested positive, what different types of steps I could take, managing those risks, increased surveillance, prophylactic surgery. But I was not ready to get genetic testing. In fact, what happened was I contemplated genetic testing for a long time. um, I was given a saliva test kit, and I put it in the back of my safe in the very back of my closet. And it just sat there. And, you might ask why, but, I had seen what happened to the women in my family alongside their careers, their families, their hobbies. They were diagnosed with breast cancer, and I watched them navigate so many complexities and uncertainties. So I wanted to be absolutely sure that if I tested positive, I was ready for that information because I knew it could potentially change my life. Um, and so in 2013, I tested positive, and that really started my journey of increased surveillance. Uh, it's influenced the research and the professor that I am today. And I've just been embracing my previvor identity since then.
You mentioned Force, the organization that I guess coined the phrase
Mhm.
"previvorship," facing hereditary cancer empowered. It's good to point out here that there's a lot of talk around BRCA testing as it pertains
Mhm.
to breast cancer. But according to the Force website, facingourrisk.org, um, this is the type of impact that it has. Not only does it have an impact on increasing risk of breast cancer, a lifetime risk with a BRCA2 mutation is between 55 and 70% compared to the general population of around 12%. But it also affects um, the increased risk of ovarian cancer, prostate cancer
Mhm.
for men, breast cancer also for men. Hello, because men do
Yes.
get breast cancer, prostate cancer, and pancreatic cancer. So even though we talk about genes in relationship to certain diseases, the reason why we do this podcast, Dr. Crizel, is to really educate the public around the multi use of this information, and not to be intimidated by it, but to be empowered by it. And you do
Mhm.
that through your work in communication. You're a communicator, you're a professional communicator. You teach people how to communicate, specifically in the area of healthcare, which is like, this is what we're all about. So, did your professional experience kind of spark your interest in becoming a researcher, or how did you decide to go this career path?
Yeah, that is a very interesting question. And the short answer is yes, definitely. I mean, the main reason why I decided to become a researcher was to give back to the medical community who saved my mom's life. She's a 28-year breast cancer survivor. And those early childhood experiences, they really sparked my early interest in medicine, but particularly communication and how communication is either used or not used very well, to understand what's going on in a family, going on with a patient, and ultimately can be used to improve patients and their family members' health experiences, decisions, and outcomes. And so I knew I wanted to give back to the medical community, but I also knew that I could not become a surgeon or a physician. Growing up in those hospitals, I still to this day I hate the smell of the hospital. I really don't like seeing blood. Um, but my family was all in education. My mother was a community college professor. My father was a school social worker. My brother is a school psychologist and adjunct instructor. And my grandfather, Marlon, who I have the BRCA2 mutation from, he earned his PhD and was the dean of a university towards the end of his career. And
Wow.
so I just really felt like when I knew I couldn't do the medical side, I thought maybe being a professor might be the next best fit, right? And so I started doing research, being on research teams at Michigan State University when I was an undergrad, and I realized, wow, you can do research on the biopsychosocial side of living with illness and disease, right? Not just the physical side effects, but the emotional, the psychological, the social side effects of living with disease and illness. And then I got um, on a research team that was looking at breast cancer communication and environment, and the rest is his history.
Wow. And in your work, you help doctors, those providers who are engaged in patient care, become more effective communicators. Why are you so passionate about patient doctor engagement and helping doctors communicate more effectively with the people they care for?
I'm really passionate about this because we know from research that those who engage in specific proactive communication behaviors, we have better health outcomes and more satisfactory experiences. And so by teaching future healthcare providers, whether it's in my undergraduate classes now or in workshops or in my research with clinicians within the genetic risk space, I think it's really important to explain that, even though physicians they go to school for years and years and they train to become experts in the body, it isn't just about the physical aspects of living with disease and illness. And so it is how we communicate with patients that can really make a difference, and not just verbally, right? But non-verbally. When you're breaking bad news and a physician like lightly touches your arm, or hands you a Kleenex, or a physician sits down right next to you. And so there's not that power difference between the physician standing over you, but sitting next to you, coming alongside of you.
Mhm.
There's so many different types of communication skills that can really make a patient feel heard, their emotions validated and acknowledged, and feel like they're coming into the situation where they're not alone and they can make informed decisions with the physician.
You just described, a lot. It's empathy training, and I think, you know, I think we've all kind of been, if you're a certain age, you've been in situations with a healthcare provider where you walked out and you just did not feel heard or seen. Um,
Mhm.
I've talked to many guests on the podcast about those things and getting to doctors that communicated in the way that was best for them. You just talked about the
Mhm.
communication styles. Do you teach communication styles to clinicians, and what are the different communication styles?
Yeah, that's a great question. I wouldn't call it communication styles. So rather we teach specific communication strategies. So like I
Mm,
said, you're teaching skills like active listening, where you are paraphrasing what the patient is saying, or you're making eye contact with them. You're engaging in building trust and rapport, asking them about their narrative, about their family history, getting to know them as a person. And you can do that in a few minutes. It doesn't have to take a really long time. Um, Strategies like checking understanding. Um, every patient has questions, right? I mean, even me with my, PhD in healthcare communication, and I've been living as a previvor for over 10 years now. I see clinicians all the time. We always have questions. We always leave an encounter with, oh, darn, I should have asked this, right? So if clinicians can normalize asking questions, not like, do you have any questions, but what questions do you still have, right? That act of normalizing and checking understanding can be really helpful. Um, Responding to emotions is another important skill that I encourage clinicians to use as well, particularly with the oncology space.
a lot of what we talk about on the podcast help our listeners learn the language, right?
Hmm.
So a lot of times when we go to the doctor, um, doctors will speak over our heads, right? And I interviewed Art Still. He's a Kansas City Chiefs ex football player. And he mentioned, he's like, man, I don't like going to the doctor because they talk over there. I don't understand what you're talking about. So, but
Yeah.
that's real. Like, and so there's a hesitancy sometimes for us to interrupt the doctor, even when what they're saying is kind of washing over us and we're catching and seizing on every
Hmm.
other word. What are some common reasons for miscommunication, specifically in medicine, from clinician to patient, that you've observed or seen?
Yeah, I so appreciate this podcast for that very reason. And I think you're raising attention to something, which is that, patients, we are not trained to be effective communicators in medicine, right? Physicians go to school and we receive no formal training. And so we're thrust into these really difficult emotional, distressing situations where we're dealing with uncertainty and we're having to make these decisions sometimes very quickly. Even navigating caregiving, right, with aging parents, or spouses. So one of the things I teach in my undergraduate classes are specific skills for empowering patients and helping them be active participants in medical encounters. And the main reason why I do that is because we know that miscommunication is one of the main causes for medical errors. It's such an important aspect when you are in a healthcare encounter. And I think the one of the main causes of miscommunication in medicine between patients and doctors is that we have different assumptions and oftentimes have different goals. So if
Mm,
you think about patients, we often feel like physicians just want us to get to the point, right? They're super busy. They're leaning on the door. They're looking at their iPad. And I want to acknowledge that physicians live in a really hard time right now. They're functioning in a really difficult space as well. So they are pressed for time. And then you've got physicians on the other side, right? A lot of physicians tend to think patients share too much irrelevant information, things that isn't related to the reason why you're in the clinical encounter. And patients focus too much on emotions or, environmental concerns or, psychosocial issues. And so there's really this conflict. There's a conflict in the care. Physicians are focused on the physical body, the patients are focused on this holistic, approach. And so because of that, there's this miscommunication that happens, and then nobody's satisfied at the end of an encounter, which can
Yeah.
be really frustrating on both sides, right?
Yeah. I recently spoke to Dr. Beatrice Preti, who wrote an amazing paper, and it was titled No versus No, KNOW versus NO. And the essence of the paper was written to clinicians on how to effectively communicate and listen to patients in a patient-centered conversation, and
Mhm.
building trust to get to shared decision making. And it's kind of the work that you do and you research. So, um, can you define like patient-centered care, because it's a term, but you would think, I mean, the it's implied in just patient care, but what is patient-centered care, and is there a way through communication strategies to achieve shared decision making in this new era of personalized medicine?
Well, I haven't read that article yet, so I will make a mental note, and I would love to read that. But yeah, so patient centered care, and then patient centered communication, which comes out of that perspective, is coming out of that biopsychosocial model of medicine. And it's really where you are, as the clinician, you are eliciting, you're trying to understand, and you're validating the patient's perspective, their lived experience, right? Their concerns, their feelings, their goals and expectations, and from their specific cultural and social context. And then it also involves working together to reach a shared agreement about the issue, the reason why the patient is in the consultation. And then lastly, really sharing power in decision making, like you're getting at, where you're offering involvement in the decision making process. And so coming into the encounter and having that approach then really sets you up for effective shared decision making. And shared decision making is a collaborative, flexible process. So it's not just something the clinician does. Again, what I think is really important here in patient centered care and shared decision making is that it is the patient who is an active health participant, an equally valued member on the team, right? We are the experts of our bodies. And so shared decision making is this collaborative process between patients and clinicians, and sometimes family members, right, depending on the context. And it's integrating, okay, what's the best available information and evidence with the patient's values and preferences. So what matters most, to us. And so shared decision making really works best when clinicians are clearly explaining the relevant evidence, right? The pros, the cons, the risks, the benefits, but then also supporting and understanding the values and preferences of the patients. And so the clinician and the patient, they're discussing, they're deliberating, they're deciding on next steps together.
Yeah, I think that's amazing, and I will send you the link to that ASCO
Please.
article. And she was so gracious enough to come on the podcast and talk about it. And you were essentially echoing a lot of things that she said, because,
Oh,
um,
good.
gosh, I wish I can go back in my brain, and the term that you mentioned is like not patient centered care, it's patient centered communication,
Patient
right?
centered communication. Yep.
Well,
Hmm.
because what she essentially did is like wrote an article about the day in the life of patients who came seeking a second opinion, and some of the
Mm,
notes in the patient's chart where they refused chemo, this, that, and the other, or they refused whatever was offered. And her
hmm.
perspective was they didn't actually refuse it. Maybe they didn't understand it. And maybe that clinician didn't ask them about their goals. And a lot of times, she said, patients don't know that they have a choice, or they have like
Yeah.
is anyone's interested about what they want to do or the goals for care. So I think that's a pretty big thing, um, in helping clinicians communicate more effectively, especially in this era of precision medicine. We're learning
Yeah.
so much about genetics every day, every year, something new comes out. And the good thing is, for cancer patients, there's more choices and more options coming than ever before. How do you
Hmm.
see, social media is like the gift and the curse, but how
Yep,
do
I
you see,
agree.
I mean, how do you see social media as being like a resource for patients to learn about genetics and genomics? Obviously, my platform is on social media, but can social media be a valuable resource for patients and clinicians?
Yeah, I think so. I think that social media is valuable when we as patients use it thoughtfully, right? It provides us access to both medical information and social support. So if you take, for example, hereditary cancer risks, previvors were using the internet and social media to learn about prevention and treatment options, but also living with hereditary cancer risks, communicating with our family members, connecting with people who are in similar situations because it's not always a very common condition. It's hard to find people who are living in a similar situation. But I think, like you pointed out, what's difficult is that information is changing rapidly. And so we've got uncertainty that plays into that. And more information isn't always better. And
Hmm.
so it is important as patients to look for trustworthy and credible information. But also, I think when you are actively using social media, for example, coming in with a frame of mind, am I looking for accurate medical information that might inform decision making, or am I looking for social support, for example? Those are two very different goals. And so the information that you're finding is going to influence your approach, I should say, is going to influence what you're looking for. So being really mindful of that, I think, can also help when you're looking for trustworthy and credible information.
Dr. Cruzel, whenever I have a guest, whether it is a patient, a previvor, or an expert, of which you are a previvor and an expert, in this area of communicating, complex topics, I love to ask our guests for three practical tips. Now, obviously, this is not a medical education show, but this is a show where we want to equip our listeners with actionable steps, actionable
Mhm.
resources, things that they can actually take action on to become more effective advocates using genetics and genomics for healthcare decisions. So, um, if you had to suggest or offer three practical tips to help someone become a more effective communicator, to advocate for a precision medicine approach to their care, what would be those practical tips?
I love that you formulate that and ask that of your guests. I think again, as patients, we're not trained to be patients, and yet we're just thrust into those situations. So, in terms from a communication perspective, there are specific ways in which you can actively participate in your medical encounters. So I'll give you two practical tips there, and then I'll circle back around maybe to social media and the internet. The first tip I would have is agenda setting. So, this means that when you go into a medical encounter with any type of clinician, you're going to tell them what you would like to talk about and verify that you have time to talk about that before moving forward. Again, this kind of gets at that miscommunication and making sure you're getting what you want out of an encounter. And the goal is to come to that agreement before time really slips away. And so that would be the first. The second is asking good questions, but not just asking good questions, clarifying. Clarifying is something that I think we underutilize as patients. So, in terms of asking good questions, I think we're often embarrassed or sometimes ashamed to ask specific questions. but expressing our concerns and our goals, like you were talking about early, is so important. And so, to help prepare you for an appointment, you can write down some questions you think you might have, and bring them with you. Maybe make a note on your phone about some recent websites you've been to or social media that you found that you want to talk to your doctor about, is another suggestion. Using AI. I think AI can be really helpful in terms of, saying, I have an appointment with my, ex clinician, and what types of questions should I be asking, and use that as a way to prepare for your appointment. But then in the end, at the end of a medical encounter, I think it's really important to check your understanding before leaving. Clarify that you understand the diagnosis, or information that was being described, and then making sure you also understand next steps as well. And then one final tip I would suggest is for using the internet and social media and for health information, and that is to limit your information seeking.
Hmm.
I think because we have so much access to information, it's really easy to get overwhelmed with the information, because information can be ambiguous, it can be unpredictable. And so by setting limits actually helps you mitigate and find information in a good way. So you could set a timer on your phone, or limit the social media on your phone as well. Again, more information is not always better. It's really being able to critically evaluate the information. So the source, the content, is there a date, who's writing it, where is this information being posted, how is it being circulated. So hopefully those are a few tips that will be helpful to some of your listeners.
Absolutely. It's helpful to me. Um, I know getting on social media can be overwhelming, but that is a good maternal instinct to protect people, to say, listen, like, not all information is good information, and too much information can be too much. But
Mm-hmm.
that's why we bring you experts like Dr. Cruzel, who can tell you these things from the insider perspective to help you become a more effective advocate and also protect your mental health along your genetics for healthcare journey. Dr. Cruzel, if there's someone out there and they want to get in touch with you to bring you in to speak about these things, or have you to conduct a communication clinic, how do they get in touch with you?
Yeah, you can reach me on my website, which is www.marliadeancruzel.com. There's a speaker page there. I'm pretty active on LinkedIn. That's my main social media space. So would love for you to connect with me, send me a message. And then I also have a YouTube channel. If you're interested in learning more about communication of genetic risk information, family communication, I have a TEDx talk that you could watch there, and some other different types of talks for patients and organizations.
Well, okay. So before I let you go, I got to ask you about the TEDx talk, which is seemingly
Okay.
amazing. It's on my bucket list too. By the way, we're going to have all those links to her website and LinkedIn pages on the episode page at geneticsforhealthcare.com episode page. So if you're listening to this through all of those other means on the go, you can go to our website and find those pages. But tell us about your TEDx talk.
Yeah, it was an awesome experience. I talk about how to make decisions in the wake of uncertainty. And so I
Hmm.
draw on my experiences being a BRCA2 previver, but also a researcher and professor, who helps patients, previvors specifically, make informed health decisions when they're facing an uncertain future. And it was a great experience. I loved it. I will share a tiny interesting thing that happened. I was actually pregnant with my son at the time of the TEDx talk, and it was quite early. And so I threw up in the bathroom. And then I went on stage, I gave the talk, and then I went to the bathroom and I threw up again. So,
Yes.
it might, I want to normalize the fact that it's a really cool experience, and I loved every minute of it, but we're also humans too. And so I teased my son that he was with me, from the very beginning when in my work.
Oh, that's an awesome share. I'm sure it wasn't an awesome feeling at the time, but I appreciate you sharing.
No.
Dr. Marlia Dean Cruzel, thank you for being a guest on Genetics for Healthcare, podcast for patients.
Thanks so much, Rome. I appreciate the opportunity, and I look forward to other episodes that you have.
This is Genetics for Healthcare, a podcast for patients.